much. Thank you for continuing to host this. It's like, feels like it's been, I think, 2 years, right, that we're doing these, and we've had over 100 programs. It's been quite a journey and actually led to some pretty amazing connections, including probably the sort of impetus for this paper that we got to publish this past month, and just sort of this program and sort of some of the work that we're trying to really kind of catalyze. That's, I think, got some good momentum going. So we're excited to have this program and really talk about women in Parkinson's and the issues that they face every day. And I think typing it all out and putting it on a paper has really sort of made us realize how bad a job we've done about caring about this, and probably not just this population, but even the intersection of women and many other populations and other populations in and of themselves. So the LGBTQ sort of populations, the racial sort of disparities that we have throughout our healthcare system. And it is Black History Month as well. And I know that there's some great content out there. So urge people to seek out and learn more about all of this content and important sort of areas that we really need to improve care in. So thank you for hosting this PMD Alliance, and for having been an amazing sort of partner in many of these out of the box discussions. So it's I'm thrilled to introduce you all to one of my colleagues, Adrienne Keener, who was a resident with us and at UCLA and my fellow, and now I'm thrilled to say has been a colleague of mine as fellow faculty, and she helps amazingly run our clinic at the VA and does some amazing education. She's fluent in Spanish and just really an amazing advocate for so many populations, and just very proud of how what an amazing clinician and educator she is. So I was able to convince her to come on this program and help teach everyone about the content of this paper and kind of break it down, because people have been hungry to digest this content, and the paper is a little bit overwhelming. There's just a lot of unmet needs. And so that's what we're going to do today. Adrienne's put together a beautiful slide set. She'll teach you a little bit about kind of what the background is of some of these sections. And then I will teach about some practical points, and we'll share with you a blog link and some ways that you can hopefully advocate for yourselves as women living with Parkinson's, or if you're a caregiver of a woman living with Parkinson's, you can advocate for them as well. And I think, talking about these specific populations, people are always like, well, what about this population? What about that? I mean, the more that we care about every population, the better off that we're serving everyone. And that's why I think, we've been talking about global issues in Parkinson's treatments, and really just, I think if you have, it's sort of a huge global family of patients that we're really advocating for. So I think any of these needs, and any one of these needs, if we can resolve, will be a tremendous step forward. So without further ado, Adrienne is Dr. Keener, has trained pretty much in California. She's a local native of California, and went to medical school at USC, was undergrad at San Diego, and then was one of our neurology residents at UCLA. And so maybe we'll learn, Adrienne, a little bit just about why you went into neurology and why movement disorders, and then why this area of women has been a little bit of a passion for you recently.
Yeah, thank you so much for having me today. And I'm pleased to meet all of you virtually and share this paper that we just published last month, as Dr. Subramanian said. So as she mentioned, I am a California native. I came to medical school really knowing that I wanted to be a neurologist, and my interest really came from my personal experience with my grandmother growing up, who had Alzheimer's, and she and I were very close, and while that was obviously emotionally impactful for me to watch her go through that, part of me, who is also very intellectually curious, found it very fascinating that she was an immigrant, and as her disease progressed, she actually lost her ability to speak English, which was her second language, and reverted to only being able to speak Portuguese. And so I was like, the intellectual part of me was curious about that. And so when I got to college, I studied cognitive science with a specialization in neuroscience, very interested in how the brain worked, and how diseases that affect the brain really impact a person's identity and relationship with the world around them. And so I came to medical school knowing I wanted to be a neurologist. And part of why I found my way to movement disorders was because of wonderful mentors like Dr. Subramanian, who continues to be a wonderful mentor to me and giving me opportunities like this to share my passion and my interests. What I really love, I think, most about caring for patients with Parkinson's disease is the relationships that we form. That doctor-physician, sort of doctor or patient relationship, I think is really special. And I love getting to know patients and their families and walking them through all stages of this disease from beginning to end. And so I think as I have been doing that as a fellow and now as faculty, perhaps being a young woman myself, I've accumulated, I think, a large group of young women who also have Parkinson's disease. And I think seeing their struggles sort of uniquely different than some of my other patients with Parkinson's disease, whether it's caring for young children or caring for elderly parents. I think, I really identify with where they are in their stage of life and the way that their Parkinson's affects that, I think, spurred my interest in this area.
Beautiful. Well, without further ado, maybe we'll jump into your slides, Adrienne, so then we can get to some chat after. Perfect.
Yeah. So I'm going to share my screen here. Okay, so the title of our paper, Unmet Needs of Women Living with Parkinson's Disease. We'll dive in and talk a bit more about its contents here. So first off, who has Parkinson's disease? So we know that about 60,000 Americans are diagnosed annually with Parkinson's disease. And study after study epidemiologically has shown that we know women have a slightly lower risk of Parkinson's disease compared to men, though interestingly, that ratio is different in different parts of the globe, perhaps due to difference in genetics or environmental exposures, or even in the ways that cases are counted. But looking here in the United States, for example, you can see in this chart that across all ethnic backgrounds, men have about 1.4 times increased likelihood of being diagnosed with Parkinson's disease compared to women. I had the opportunity to get involved in addressing the needs of this large minority group of women with Parkinson's disease through a collaboration with the Parkinson's Foundation. And I think I want to highlight here Sharon Krisher, who is a wonderful advocate of women living with Parkinson's disease, who I think may be joining us today too, who really invited me to participate in this effort. And the goal of this effort was really to identify research questions to further elucidate gender differences in Parkinson's disease, raise awareness among clinicians, scientists, patients, and the public, and develop tailored interventions that meet the unique needs of women and men with Parkinson's disease. And so this was really sort of a great experience a few years ago where we brought together different stakeholders, including patients and physicians, in the same room, in small groups, to chat about, how could we really address these gaps in care. Years have gone by since then, however, and I think we still recognize that we have a long way to go into putting these things into action. And so this paper, which Dr. Subramanian spearheaded, I want to highlight, also includes, as three of the authors, voices of women living with Parkinson's disease. And I think all of them have been on this program in the past, talking about their advocacy work, some of the science relating to sex and gender and Parkinson's disease. And so I would refer you to sort of watch those recordings from these prior sessions on the wHolistic series as well. So why is it that women are less likely to be diagnosed with Parkinson's disease than men? So when we think about who's at risk for getting Parkinson's disease, we think about a combination of genetics or biology and environment that predisposes somebody to developing Parkinson's disease. So in women, it may be that women are less likely than men to be exposed to certain environmental factors that have been associated with Parkinson's disease. things like pesticide exposure, for example, traumatic brain injury. There also are obvious biologic differences between men and women. And this we largely think of as hormones, but there are also other genetic and biologic differences between men and women that may play a role in the risk of developing Parkinson's disease. So estrogen is the main hormone that we think of when we look at Parkinson's disease risk in women. And there are several preclinical studies, so looking at the basic science or the animal models of Parkinson's disease that support a protective role of estrogen. For example, in one of the most well-established models of Parkinson's disease in mice, the MPTP model, we see that the toxin itself is more toxic in male mice compared to female mice. And just to point out too, the majority of research is actually done on male mice. Also, estrogens have an anti-inflammatory and anti-apoptotic effects in preclinical studies. And this graph here, this image here is from a study that demonstrated that estrogen could also inhibit alpha-synuclein aggregation. And so in panel A here, these are alpha-synuclein fibrils forming into these sort of aggregates. In panel B, all they did was add estrogen to the mix, and you can see it sort of inhibited that formation. And so estrogen likely has a direct impact on the pathology of Parkinson's disease. We also see in epidemiologic studies that women who have a higher lifetime estrogen exposure have a decreased risk of Parkinson's disease. So here at UCLA, I participate in our Parkinson's environment and gene study, looking at a population in the California Central Valley. And within that cohort of patients, we have shown that increased menopausal age reduces the risk of Parkinson's disease. However, I'll point out here, and what is highlighted really in our paper is that many of these data also have sort of conflicting results. So there are also some epidemiologic studies that show that estrogen exposure does not seem to be linked with Parkinson's risk. I think part of why some of those results may be disparate is that the timing and duration of hormone exposure is probably one of the critical aspects. So for example, whether or not you experience natural menopause or surgical menopause, this may play a role on your estrogen exposure and its relationship to risk of Parkinson's disease. And even perhaps the type of hormone replacement therapy that you choose and how long you take it may also impact your Parkinson's disease risk. So estrogen, I think, is considered a strong candidate for why women have a lower risk of PD than men. But even the story here is not completely clear. And so this is one area where further research is needed. We also see that estrogen or female sex rather may modulate other risk factors for Parkinson's disease. For example, caffeine is linked to a lower risk of Parkinson's disease among men, but not women. And there is actually a study that showed that among postmenopausal women, those who were taking hormone replacement therapy and consumed caffeine actually had an increased risk of Parkinson's disease. Non-aspirin NSAID use has also been associated with a lower risk of PD in men, but actually a higher risk of PD among women. So we don't fully understand what's going on there. And exposure to urate lowering medications has also been shown to decrease risk in men. But for women, this association was only seen in postmenopausal women when urate levels are more similar to those of men. So again, I think the life cycles that women experience, the changes in their hormone status, can interact with these other risk factors for Parkinson's disease. We also know that once diagnosed with Parkinson's disease, women and men have a very different experience in terms of their symptoms, their response to treatment, and even their access to care. So Parkinson's disease generally starts earlier in men, about 2 years earlier on average. We see that women tend to be more prone to develop a tremor-dominant phenotype of Parkinson's disease, and also experience non-motor symptoms more frequently, including pain and mood symptoms such as depression. We also see that when we look at quality of life, that different non-motor symptoms have a greater impact on quality of life for men compared to women. For example, depression and fatigue seem to be the main drivers of poor quality of life in women, whereas cognition was one of the main drivers in men. This paper is one that's cited in our paper. That's an excellent review looking at not only the different genetics and biologic factors, but also some of the differences in clinical presentation between men and women with Parkinson's disease. We also see that women have a unique hormonal influence on their symptoms. I think any of us who care about a woman with Parkinson's disease has heard about these fluctuation in symptoms based on their hormone status. So worsening of their symptoms before their period, worsening of symptoms during pregnancy and postpartum, and also worsening of symptoms in that time leading up to menopause. So this is one of the figures from our paper, sort of demonstrating that, you know, we really, as physicians and as patients and caregivers, need to be attuned to these different hormone cycles that women experience throughout their lives and the way that it impacts their Parkinson's disease. We also see that women with Parkinson's disease are at an increased risk of other serious comorbidities with osteoporosis and hip fracture in particular being much higher among women with Parkinson's disease compared to men. And this obviously can have a huge impact on quality of life and is one of the leading actually factors for placement into a nursing home or needing a higher level of care. Should men and women be treated differently? Well, we do see that in response to treatment, women are more prone to develop dyskinesias and motor fluctuations. And biologically, we can see that there's greater bioavailability of levodopa in women, and that the genetic determinants of dyskinesias may differ among men and women. And so most studies that have led to new medications for Parkinson's disease have involved primarily men in those clinical trials. And so we're not really tailoring our drug treatments to women, but perhaps we should. When it comes to our surgical treatments for Parkinson's disease, like deep brain stimulation, we also see a difference in that women actually have greater gains in quality of life compared to men who undergo DBS, but are much less likely to receive DBS for their treatment. And there are several factors that might be responsible for these observations. One may just be patient preference. One may be the perceived risk of some of these interventions like DBS. Another may be possible physician bias. So we are human too, and is it that we are not referring women at the same rates that we're referring men for advanced therapies like DBS? Other health conditions or comorbidities may also influence treatment decisions. And finally, as I said, you know, we really don't understand fully drug safety, drug efficacy, drug tolerance and metabolism in women specifically. And so all of our treatments are sort of a one size fits all and tailoring that based on somebody's body weight or gender or race is not something that we have knowledge about. Finally, there's a difference and a disparity in terms of women accessing care for Parkinson's disease. So this image is sort of the textbook image of a patient with Parkinson's disease. It's an older Caucasian man. And the first step to getting the right treatment is, of course, getting the right diagnosis. We know that Parkinson's disease is a clinical diagnosis based on the motor symptoms. And as it stands, we don't have any current biomarkers to help us with that diagnosis. So I think we need to highlight that it is time for a new image of Parkinson's disease. This was a paper published in 2020 by Mike Oken and his colleague, really emphasizing that that even as medical providers, we need to broaden what we think of when we think of what Parkinson's disease may look like. Because if we're not diagnosing women accurately, then of course they're not going to get access to the right treatment. We also know that women are less likely to see a neurologist for their Parkinson's. This is a disadvantage, of course, because studies have shown that patients with Parkinson's disease who are treated by a neurologist tend to have better outcomes. We also can see in terms of the delay to diagnosis and delay to referral to subspecialty care that women have a much longer time course. So taking longer on average to see a physician, longer to get that diagnosis from the physician, and then still longer to get a referral to a movement disorder specialist when compared to their men counterparts. And in the long term, we also see differences in the care for women with Parkinson's disease. In general, they're less likely to visit a physician regularly, more likely to be placed in a skilled nursing facility, more likely to receive home health care, and also more likely to receive hospice care. And there are several psychosocial barriers that may be affecting women's access to care for Parkinson's disease. And this is, I think, one area that really has been sort of underemphasized and that we tried to include and really address in our paper. But women, often assume a caregiving role for others, their partners, aging parents, children, grandchildren. And there are some studies that suggest when in this role as the caregiver, women often neglect their own health problems. And we also have studies that have shown that caregivers in general are more likely to be in poor health and experience problems getting the care that they need. So because women often fill this role as the caregiver, they might not be taking care of themselves as well as perhaps they should be. And I like to highlight this quote here, which was from a qualitative study looking at the impact that the diagnosis had on women with Parkinson's disease. So this patient said, although I realize that getting the disease is not my fault, it did compromise my roles as a mother of a young child, the daughter of an elderly parent, a wife, and a business partner. So we know even at the time of diagnosis that women report worse disability and health-related quality of life compared to men. There are studies that have also shown that women have an alteration of their perception of their own womanhood, a loss of a sense of femininity with this disease that can impact their relationships. There is one non-motor symptom, sexual dysfunction, that in all studies seems to be more common in men, but we sort of raise the question of perhaps women aren't being asked about this, or perhaps are not feeling open enough to address this symptom with their healthcare providers. So I think all these changes in a woman's sort of role in society and in their relationships are really important to address as part of their care. I'll also highlight here that women with Parkinson's are more likely to live alone and therefore not to be accompanied to their office visits with their physicians and more likely to have to pay non-relatives to assist in their care. And so the dynamic in terms of partnership and caregiving is also different for women with Parkinson's disease compared to men. And we need to think about this, especially as we're thinking about long-term care. So this is another figure from our paper that I just wanted to highlight as sort of a summary, reviewing the differences in motor and non-motor symptoms, as well as those important psychosocial issues that impact women with Parkinson's disease in particular. And lastly, a very brief history lesson of women in research. So historically, women have actually been purposefully excluded from medical research. And it wasn't until 2012, which seems very recent to me, that the FDA Safety and Innovation Act was passed, which really required the FDA to provide an accounting of sex, race, ethnicity, inclusion in clinical trials. 2018, however, led to this publication titled aptly "The Underrepresentation of Women in Parkinson's Disease Trials," sort of highlighting that this is still a major problem that we have not really adequately addressed. So I think, we find that there are a lot of gaps in care for women with Parkinson's disease. There are areas of the science that are poorly understood that need more attention, and we need to get more women involved in the research so that we can make progress in some of these areas. With that, I'll hand it over to Dr. Subramanian to give you guys 15 take-home points. Thanks.
Thank you. That was awesome, Adrienne. Great review. And yeah, I mean, just to see it all in slides and realize how many gaps there are is quite astonishing. So yeah, so we thought, that was the meat of our paper, just the data, and those figures are in the blog. And then in the blog that we'll send you to as well, you can take a look at these 15 things, but we thought it would be nice to have sort of some take home points. And so this past 2 years, outside of supporting this support group here at Wholistic and some other adventures, I've been blogging weekly with another amazing Parkinson's advocate partner, Michael Oken, on his blog site, parkinsonsecrets.com. If you don't know about this blog, you should know about this blog. Anyone who cares about Parkinson's disease, there's a huge amount of wealth of knowledge. Mike's been great about posting things around COVID vaccinations and different sorts of practical tips that are very, very timely, but also we've been trying to feature more content around disparities in care, really highlighting sort of the gaps for people, including women. We're hosting a number of blogs in the last month or so, and we'll continue to host some by our co-authors, Rochelle Flanagan, Sonia Mathur, and Annalyn Oosterban, who I will point out is just a force of nature. She's actually delivering her 4th child imminently. So we've just had, just an amazing time with this collaboration, along with Dr. Elena Morrow, who also helped kind of advocate and approached the Movement Disorders Journal, and we were thrilled to have our paper accepted. So unfortunately, this is not an open access paper, so we're really trying to highlight a lot of the information through programs like this and through the blog, and trying to give practical tips. If any of you out there have connections to media, we would love to have interviews to really get some of the disease state knowledge out there. I think it's really important that this call to action is amplified, and that we can get this message to anyone who can hear it throughout the world. It's really heartbreaking in some countries that women are misdiagnosed, including in our own North America, on a daily basis, and that these diseases are being missed in women, especially younger women. And in some nations there's a shame factor. Patients are hidden by their families in parts of Africa, India, other places, and really not getting the care that they need. There's a huge stigma. So the only way that we're going to really change that is by increasing disease awareness about who gets this disease, and having people understand that there are treatments that can really change outcomes. And the only way we're going to do that is to have each and every one of us be part of that message and amplification. So if you have any contact with media, news, anyone who will listen, we're happy to talk to them, and please reach out. So maybe we'll switch to the next slide. So we just thought we'd put together some practical tips. So number one, it's important for women to realize, as you just heard, that women can absolutely get Parkinson's. And even though if you Google Parkinson's disease, the images that are going to come up are all going to be, older white men. It's pretty striking. I urge you to try that. This is the image huge that we are in medical schools educating our young physicians and trainees around, and this is what they take with them throughout their lifetime of practice, to think that that is the image of who is going to present to them. We have to change that. And so we really need, again, to get public service announcements out and really be re-educating clinicians throughout the world and changing the way that we educate medical students about this disease. And this paper, along with, sort of partnerships like this, is the only way that we're really going to do that. So that's number one, is disease awareness. And number two is really getting knowledge that is, powerful. So getting knowledge from places like the PMD Alliance, the Parkinson Foundation, the Michael J. Fox Foundation, the Davis Phinney Foundation, our blog spot, theparkinsonsecrets.com. If you get good information from vetted resources, it's going to really help you to understand what you can do to change the outcome of this disease. And Dr. Keener and I every day counsel people on the types of things that they can really do to change these outcomes. And so it's really important to have hope, to be part of the dialogue, to really find the right information and get the right path to really thriving. So number three is that, Parkinson's is not just a motor disease. The things that really affect quality of life are around non-motor issues that we've mentioned. So if you're having these sorts of things and you have a clinician that doesn't know enough about the disease, because normally, again, people are taught about tremor, stiffness, slowness, and balance problems as the main symptoms. That's what we educate our young medical students around, and that it's a disease of, older men who are white. And so if that's the entire snapshot of what people are thinking is Parkinson's, they're really not going to be asking about these non-motor issues that make a huge difference. So that's important, that you get care and that non-motor issues are part of this disease. The other thing that's very important, and that we've seen not only now with COVID, but I think we've highlighted, and I just wrote a paper on mental health manifestations, and the next wHolistic episode in March is going to highlight, along with a colleague of mine, Greg Pontone, who's a psychiatrist, around the importance of getting care in the mental health arena. But anxiety, depression, apathy, sleep difficulties, all very, very impactful for all people with Parkinson's. Important to know that. Number 5 is that hormonal cycle slide. We have a beautiful graphic that was illustrated actually by one of Dr. Morrow's patient's daughters. And I just love that graphic. And I think to see that graphic, to see the stages in which patients can get worsening, the perimenopausal time, that period time, premenstrual time, the week before people get their period, really often patients feel worse. And so we have to understand that, talk to your doctors about this, really bring it forward. You can take that image from that blog in if you feel uncomfortable bringing it up, and hopefully start some dialogues. Next slide, please. So we talked about education. Next is getting the care that you need. So really getting help from experts. So Dr. Keener and I, we did a 2-year movement disorder fellowship, and we are a rarity actually in the country. And in the world, some countries only have one of us, if not 0 of us. Some people don't even have neurologists in their entire country. For example, Haiti, some parts of Africa, really very, very, very minimal neurological care. So if you have access, it's really important to try to see one if you can, if you have Parkinson's, to get the diagnosis established. So at the beginning of your disease, I think it's reasonable to check in with a movement disorder neurologist at that time. And then other checkpoints, especially if you're a woman, if you're thinking of getting pregnant and you're a young woman, check in with a movement disorder doctor, because there are certain medicines that you may be on that are not safe to get pregnant with and can affect, your ability to carry that baby safely to term. So make sure you get in to see a movement neurologist if you're thinking of getting pregnant. Other times would be if you're having exacerbations around your period or that premenopausal time period, or even yearly, if you can check in, have good, sort of collaboration between all your providers. If people are not talking to each other, don't have access to notes, bring the notes from one doctor to the other so that you can be part of, the way to help advocate for care and improve communication. So then how can you get the best out of your appointments? And this is for not just women, but everybody. So write down your main complaints, bring in your pill bottles, write down what refills you need, figure out who are your providers, make a list so that your doctor knows those. All of that stuff really helps us to get the best care for you, and really have an advocate come with you who can take notes alongside, because it's overwhelming. And then read the after visit summaries. If you get a piece of paper and I send it home with you, or Dr. Keener or somebody like us, prints out a paper and hands it to you. That's the stuff that you're supposed to be reading. Make sure you understand it so that you can really be part of that plan of care. So number 8, if you have a provider and you feel like they're not really listening to you, then try to find somebody who does. It's important that you feel like you have trust with your doctor. We really feel, as we've talked here, that the doctor-patient relationship is a sacred one. Both of us largely work at the VA. I pretty much work at the VA full time, and it's really just important to feel like you have a good rapport. That is a huge part of, the communication. So seek and find that. And even if you have to drive an extra hour to find that, that's worth it, I think, because we really want you to have the best care. Number 9, so it may not be that the doctor is your main sort of provider. And there might be not the movement disorder sort of specialist that you see once in 3 months or 6 months for 15 minutes or 30 minutes, but really some of these other providers that you can engage too. So having physical therapy, occupational therapy, speech therapy, it might even be other people. So we've really sort of thought about how can we get care in the community, who brings you, support, and who can really help advocate for you. And it might be people like yoga teachers or a dietitian, a psychologist, a spiritual leader. So really think about who's on your team. It may not be the classic people with a bunch of degrees behind their name. It might be somebody else that really is sort of knowledgeable and understanding about your care and can help guide you. So we are open to collaborating with all of the above, at least in our clinics. Next slide, please. So then I think for women, this is a hugely important slide. And I think this is not just for women with Parkinson's, but women in general. I say this, I give talks around physician burnout to people and try to advocate for my colleagues. So taking care of ourselves as women is huge. So that oxygen mask analogy. So we tend to take care of everyone else first, and then we burn ourselves out. So really thinking about if you can take care of yourself before you take care of anyone else in your life, put yourself first, because you are going to give yourself the best nourishment. No one else is really going to do that for you in these roles. So you have to take care of yourself. And then how do you do that? Well, wellness is important. So you know that the reason this series is called Holistic is because I believe in exercise as medicine, the mind-body strategies like meditation or getting out in nature, finding things you enjoy. So really think about, what brings you joy, what brings you meaning, who brings you joy, who brings you meaning, figure out how to incorporate more of that in your life. Dr. Keener just talked a little bit about bone health and how important those fractures are. So getting, those sorts of routine care for general medical issues like, scans for your bones or mammograms, all that stuff. Take care of all of that stuff because no one else is going to do that for you. So make sure you're getting that done. Get good sleep, eat well, things like that as well. So then social connection, as you know, I've been harping on this because it's been part of my passion and research in the last 2 years, but, finding your tribe. So first of all, think about who's the best advocate for you. And I think, when we look at that data on, women and as they age and as their disease progresses, I think often male caregivers sometimes may not feel fully prepared. You might need somebody else to be, your advocate. It may not be your spouse. So really think about who's that biggest cheerleader in your life. Who can you be open to talking to about symptoms? Maybe it's your best friend, maybe it's your sister, maybe it's your daughter. Really think a little bit outside the box. Try to engage them, be honest with them about your symptoms, have them come to your appointments, have them be part of the dialogue, include them in, how you're feeling and have them check in on you regularly. So that's really, really important. They can write down symptoms and help communicate with your providers. And then, who's your tribe? So, a lot of people get kind of shamed when they get a new disease or diagnosis, and they tend to retreat, be isolated, and really, become part of the problem because they sort of shut out the people in their lives that love them. So think about who are your, friends who can really sort of cheerlead for you. Who do you enjoy spending time with? Who do you enjoy, a glass of wine or, a chat, sort of a walk in the park? Think about those people and try to reach out to them and really incorporate, things like laughing, playing, relaxing, sharing stories. These are all hugely beneficial and therapeutic and part of actually medicine. Actually, we realize that these are basic human nutrients, these social connections. Number 14 is joining a support group. We have some support group leaders on this chat today. I see Sharon Krischer, who runs Twitchy Women. And maybe we can put those ways to join those, and they're all linked in the blog. The Women Parkinson's Project. Rochelle Flanagan couldn't join us today, but there may be some folks out there. And then I see some folks from Compe de Parkinson, which is an amazing support group, which includes Spanish-speaking women, I think run out largely of Spain, and we'll be doing this talk for them as well in Spanish. And so hopefully there'll be a Spanish version of this. Dr. Keener is actually very adept at speaking Spanish, along with many of her other amazing talents. So, and then the last thing I will say is that getting involved. So, it's important to find purpose and meaning in our lives. I mean, that's just part of what drives our, how we thrive in quality of life for all of us. And for, the reason that this paper got written is actually around the stories that I was really inspired to hear through the advocacy work of the women that are our co-authors. And a lot of them were saying, as I interviewed them through these series, and I do urge you to go back and watch these, Rochelle, Sonia, and Leanne, beautiful talks, beautiful stories, really amazing advocacy. And so really when women can get together and really advocate for each other, I think it's a magical thing. And that is something that I urge you to get involved in. There's a lot of ways to do that. The PD Avengers is one. Some of the support groups that I mentioned on the previous slide. There's just sometimes a power in numbers and getting together and fighting for something that really can give people meaning. The other thing is you saw how poorly research is really reflecting women. It's really stunning how terrible this has been reported historically. The fact that the FDA didn't even require this until 10 years ago is actually sad and pathetic. And it's still not requiring equal participation for percentages of how many women are getting this disease. And so we really have to push these stakeholders to care about this more. Nacho's on the line here. Dr. Mata is doing some amazing genetics studies. I'd like to have him just say a word about a study that he's doing currently.
Hi.
Hey, Nacho.
How's it going?
Good.
First thing, thank you both for this. This is amazing. I think this is an incredible and very much needed resource. Obviously, we're huge supporters of everything that you are doing, and we were very happy to see this paper coming out. I think this is a part of the revolution that is happening right now, which is I'm very excited about. I've been working, in the genetics of Parkinson's disease for a long time. I'm probably one of those researchers that I haven't done enough for women, at least until now. Luckily, a PhD student crossed on my path who kind of made me see some of the problems that currently we have in research. And I wanted to separate a little bit research from clinical trials, because it is true that women don't participate as much in clinical trials, but we're lucky that we have quite a few women participating in research, and especially genetic research. I think the biggest problem that we have is that most of the questionnaires and surveys that we use to collect data for those studies are gender neutral. So we're missing a lot of all the factors that you guys mentioned during this talk. We're not collecting any data on it, and it is a big problem, because it's not going to allow us to understand why this difference happened between women and men in Parkinson's disease. And therefore, I think it's going to make it even harder for women to participate in clinical trials, because again, one of the reasons why they get excluded sometimes is because there's so many different factors that we don't know about what their role is in the disease, that as a researchers with very simple minds, we're like, it's better just to exclude those factors than trying to understand them, which is, I think that's the way we need to go. So we realized this very early on. My PhD student is working on a survey that we were putting together. Hopefully it will be out very soon for people to see and comment and use if they want to, because I think that's really the first step for us to be able to understand again where this difference come from and what kind of factors we need to start studying more to try to understand and put everything in perspective. I think the disease is complex enough, and I think in women it's probably even more complex because of all these women specific health factors that we're not accounting for. So again, I'm very excited about this. I think this is gonna change the way many people, including myself, are including women in our studies. The data that we're collecting, the studies that we need to perform in the next few years to be able to understand this. And obviously we need to push hard, both funding agencies, the government, everybody needs to be on board to go in the same direction, right? And push for clinical trials to include more women, for genetic studies to include more women, or even animal models. That's one of the things that I think you guys mentioned on the paper as well, that when we were using animal models to try to model the disease, a lot of the times we don't use the data for the females. We only use the data for the males, and that has put us back many years, because again, we had that data and nobody really had looked at it, because again, it's too complicated for our simple researcher mind. So I think we need to push everybody, to work together. And it's great to see that the people with Parkinson's, women with Parkinson's are getting on board. Patient advocates are getting on board. So now we need more researchers and more clinicians, jumping on board and doing the work that needs to be done to be able to fix this. So yeah. So again, thank you very much for doing this. I really appreciate this, and we're very excited for the next few years. I think there's going to be a lot of knowledge being generated, and hopefully a lot more steps towards being able to provide the best care for women with Parkinson's.
That's great. And your surveys, it's going to be web-based, right? So
yeah, the only thing is that one of the things that we were debating is if we can just put it on a website and let women just answer it. But one of the things that we want to understand as researchers is I really want to know how this affects, for example, disease progression. So not only disease risk, but progression. And to be able to do that, we need to collect a lot of clinical data. So the way we are going about this is we're trying to do this specifically in cohorts of patients where we have electronic medical records, we have all these different data, so we can all put it together. As I mentioned, Parkinson's disease is a multifactorial, very complex disease. So genetics plays a role, but environment, lifestyle, all those things play a role. So we need to have that data available. And I think the survey will be gigantic if we want to collect all that in just one place. So the way we're going about it is trying to look at the cohorts that we already have a lot of data for, that are being seen by neurologists, and working directly with the neurologists to just do this extra survey and then putting all that into context into one big model. So although it'll be available, I don't think I want it to go through the neurologists and through researchers. So we can collect the data together with all the other things. But I know that if women are participating in Fox Insight or any of the other projects, the Parkinson's Foundation has several projects like the POP project. So through those avenues as well, we'll be able to collect surveys like this and collect more data. And I think the key here is going to be, again, collaboration to me is the key, because we all need to collect similar data, so then we can compare. We can have very large number of women participating in this study, so the results that we get are truly real. Because that's one of the problems that we have right now, is that the few studies that have been done, they have less than a couple hundred women participating, and that's as a scientist, it's really hard to believe data when it comes from such a small cohort. So I think we need to get more women and collect similar data in many different places and then compare.
Absolutely. Yeah. And even if we do have women, so I also work with Dr. Mishley. Well, maybe Andrea, you can link the MVP study looking at the modifiable variables of Parkinson's. And we actually have quite a decent amount of women, but very few women of color or, racial sort of diversity. So if you are any of, sort of intersections, any women out there, please, we don't care where, just join some studies, have your voices heard. I think the more women that participate, especially in sort of internet-based studies, there's been sort of a sense that women are more likely to participate. So if you can kind of hop on and try to start to, get sort of involved, I think it can really help. There's There's also, Shilpa wrote, if any women are part of the PD generation, our survey is live there. So it sounds like PD generation, MVP, there's already some surveys that are out there. If you're feeling motivated to hop on, do that, and we'll link some of that right here. And we'll also, the PMD Alliance will link that with this talk, I think. Adrienne, there's one question about pregnancy, specifically the impact of PD on fertility and pregnancy. And thanks so much, Nacho, for hopping on. I appreciate that. Does Parkinson's disease affect fertility specifically?
Yeah, so I don't think we have any data that shows that having Parkinson's disease impacts your fertility. I think we do often hear, I think anecdotally, patients report that that it was around the time of their pregnancy or maybe postpartum that their Parkinson's seemed to start. And I think we see that perhaps it's the huge hormonal fluctuations that are happening, or maybe it's just the overall stress of pregnancy on the system that seems to bring maybe what was preclinical or prodromal symptoms to the forefront. But and we know that women with Parkinson's disease do experience exacerbations of symptoms during pregnancy, but I don't think it impacts your fertility directly. And I don't think that we know that that impact of the hormone changes that happen during pregnancy is necessarily deleterious for Parkinson's or going to change your disease course or anything like that. We just, I think, simply don't have that connection established.
Yeah, and Annelian Dr. Oosterban had done one of these holistics. You can go ahead and watch it. She talks a lot about hormonal changes, and she's really been pushing for a registry that's international to track women through pregnancy and who may be trying to get pregnant to understand this better, because we just don't have great data, and she herself is pregnant at the moment and about to deliver. So, really, and Dr. Mathur, Sonia Mathur, has actually had, I believe, 3 pregnancies through Parkinson's. And so it's definitely doable. It's just important that you work with your neurologist. Another thing that we've been kind of advocating for is more communication between neurology and OBGYNs, so that, that everyone's talking and knows what medicines, and even during the delivery and through postpartum time periods, because, the hormone fluctuations of just being pregnant, even without Parkinson's, can lead to postpartum depression and all kinds of other things. And so we don't know if people are at more risk for these things to happen if you have Parkinson's as well. So it's just, having close follow-up is important. There were some thoughts about how expensive all this medical advice could be. I mean, I hope that we can sort of work together to get information out. And I know that Dr. Oken and I have been trying to do that. And I think the collaboration that I see between, places like the PMD Alliance and, for example, Dr. Mata and all of us, I mean, I hope that, we can really sort of take away from this that very hopefully, inexpensively, we can at least get knowledge, and knowledge is power. And, getting, sort of to the right type of other patients that are also experiencing this, hopefully you can feel like you have sort of a path. And I know that, for example, the Twitchy Woman group has some mentorship. So you can get paired with somebody who may have had maybe be farther along in their disease and feel like you have someone to kind of walk alongside of you. So really think a little bit about, what the free resources are out there. Obviously, many of these resources are still available through the internet. So we're missing people because they don't have internet. And I do understand that. So we're trying to get some of these things available if we can through paper medium and to be handed out. We're also having sort of same time campaigns to educate our clinicians, so that we can try to work with the advocacy groups, the Parkinson Foundation, PMD Alliance, and other people to provide resources that can then go to clinicians' offices. And it's not just movement disorder neurologists. So we do have a task force now at the Movement Disorder Society to care about women, run by Dr. Morrow. But, it's really getting your average person on the planet to understand that their sister could have Parkinson's, and that person needs to go in and see a doctor if they're having these types of symptoms. So that's really sort of where it's really this sort of grassroots, on the ground kind of level of knowledge that people need to know. There's just a lot of comments here. Sorry, we're trying to stay abreast of all of these.
I'll just add that I think, not having access to internet is of course a barrier that we need to address. But like this holistic series, maybe one of the other silver linings of the pandemic has been really the embracing of telemedicine. And so I think for patients who live perhaps more rural areas, don't have access to a neurologist or movement disorder specialist, I think at least by telemedicine, you could reach somebody, halfway across the country to see them at least virtually. And so I think telemedicine is another way to sort of accessing some subspecialty care that might not be in your backyard. And then these other resources that are now, what used to be perhaps a local support group is now having a global reach, for example. So I think, taking advantage of the reach that technology can have can make a lot of this more accessible for many people. Though, as you said, Dr. Subramanian, the limitations of people who don't have access to internet or technology is still, I think, a barrier that we need to work around.
Yeah, absolutely. There's been a couple questions about cognition and hallucinations, Adrienne. Maybe we could just take that one and then try to wrap up. Obviously, there's so many questions and lots of comments and tons of resources, and we want to make all of those available. The PMD Alliance usually saves these chats, and we'll usually try to link these. So, and I'll try to put a link from this talk on the blog as well, so we can try to get this information out. And we're trying to really break down the blog so that we can cover almost all of the content, if not all or more than the paper has. So don't worry if you don't have access. Unfortunately, we did try to see if we could make it free access, but it couldn't work. It didn't work with the journal and the publishers and stuff. So fear not, though. We'll try to cover all the blog content. And there's also going to be for women's, I'm not even sure what the day is, Women's Something Day in March. We're going to be doing a little bit of an event with the WPC, so the World Parkinson Congress folks, around the same issue. So I think we're going to have follow-up panels and more discussion. So if your question didn't get answered or something comes up, we can always sort of discuss it in the future. But Adrienne, let me let you take the one about cognition and hallucinations.
Yeah. So so the majority of studies have shown that men are more likely to develop cognitive impairment and hallucinations. Though there are also studies that show that when women do develop cognitive impairment in Parkinson's disease, they tend to have a different profile of cognitive difficulties compared to men. So even sort of within Parkinson's disease related cognitive impairment, there are differences in the way that women manifest that compared to men. So women, for example, tend to have more visuospatial dysfunction than men when they do develop cognitive impairment. And so I think there's a lot there still to unpack. And I will also say that even with Parkinson's disease, women still have a longer life expectancy than men. And we know the greatest risk for developing cognitive impairment in Parkinson's disease is age. And so if women on average are living longer, even with Parkinson's disease, we're still going to end up with a large population of older women with Parkinson's and related cognitive impairment. So, so I think, I don't want to downplay that symptom in women, because I think it can happen in women, and it happens perhaps differently than it does in men, and maybe later, but certainly can have a huge impact on quality of life.
Great. Well, I think we're at the top of the hour. Thank you so much, Adrienne, for putting together this amazing slide set. Thank you to all the support group leaders that have shown up and given their information. And thank you, Dr. Mata, for also speaking about research. All collaboration, all so important. Hopefully we can really band together to fight for this cause, and really a call to action. Again, if you have links to the media, we are happy to blow this up wherever it can be heard. And thank you, PMD Alliance, for hosting. And it's just lovely to see everyone out there after such a long time. So happy February, and it's International Women's Day in March. So we'll join you there as well, and continue to have maybe once a month holistic. So I'm going to pass it back to Andrea to say goodbye.
Yes, what an amazing discussion, and the chat was hopping with all kinds of resources. We'll share those, but we always like to close with a wave of gratitude. So I invite everyone to turn on their video, and Dr. Keener, Dr. Subramanian, scroll through, look at all the smiling faces. Thank you, all the women who joined and our men as allies. Great to see you all. What a lovely way to spend an hour together. Bye now, everyone.